Hello and welcome to the CSF Rheumatology Author Interview Podcast for this month. My name is Peter Nash from the Griffith University in Brisbane, and today we're very fortunate to talk to one of the world's most eminent infectious diseases physicians, Professor Kevin Winthrop from the Oregon Health Science University. Welcome, Kevin, and many thanks for your time. I appreciate it's the middle of your afternoon over there, and we hope you're keeping well with all this COVID and all the fires in Oregon. So I just wonder, before we start, if you could tell the audience a little bit about yourself and how you got into what you got into and where you're working and what you're researching on.
Sure, you bet. Thanks, Peter, for having me. As you mentioned, I'm in Portland, Oregon. I'm a professor here of infectious diseases and epidemiology in the School of Medicine and School of Public Health at Oregon Health Science University. I've been here, as of today, 15 years. I can't believe it. I started when I was like 5 years old, obviously. So I got into this whole bit of working with you guys about 20 years ago when I was a younger CDC official. I was a staff epidemiologist at the US CDC, Center for Disease Control and Prevention, which has unfortunately been in the news a lot lately. My remaining friends there.
All we hear is criticism of the CDC.
Yeah, my remaining buddies there, I feel bad for. They've been kind of pushed aside by a lot of people above them, the administration, namely. But anyway, all that aside, I worked there. I was a TB guy, and it was pretty random. But Joseph Smolin called CDC and said, "Hey, we need someone to help us with this TB issue in Europe around anti-TNF drugs." And he had an old contact there who turned out supervisor at the time. And I had just done an outbreak of infliximab-associated TB throughout California and kind of figured out, what the problem was. And so I'd been working on this issue. And so my supervisor said, "Yeah, you should go to Europe to this conference and get involved." So that kind of opened the window, and I've been working on those issues with you guys ever since. And of course, after TNF blockers, they all came out, and then there was the new mechanism of action, X, Y, and Z. And so it's been a continuous flood of biologics and now small molecular therapies, who all have kind of their own infection risk or profile, somewhat similar in some cases, sometimes different in others. And I've enjoyed studying all those issues as they've come up in the last couple decades.
Fantastic. So today we're talking about your paper, recently published in Rheumatic Diseases, which is Infections in Baricitinib Clinical Trials for Patients with Active RA. So can you tell us a little bit about the objective of the study and the kind of methods that you put together to analyze this particular question?
Sure, you bet. This was a study long in coming. I mean, I feel like we worked on this for a couple years, and this was really an effort to summarize the infectious disease experience in the clinical trial program in RA for Baricitinib. So this was rating, I think, 8 phase 1, 2, or 3 studies and 1 long-term extension to one of those studies. And so all of that data combined over a number of years, can't remember, but almost 8,000 person years of exposure, I think. And so it was a summary of that data, looking at infectious disease risk by dose, and then types of infections occurring, particularly the opportunistic infections, describing their incidence and trying to compare it to the comparative regimens where possible in some of those studies. So it was really an integrated safety assessment, I think, for Baricitinib in the RA program for infection.
So it's about, as you say, 3,500 patients, nearly 8,000 patient years, mean about 2.6 years, maximum 6 years. Can you tell us, just for those who aren't clear, Barry's JAK1/2, what the profile of Barry is in the US, given the crazy FDA's 2 milligram decision? And then we're going to talk about what you actually found.
Yeah, Barry is JAK1, JAK2 primarily. Some of the other drugs have different spectrums of activity. TOFA is more like JAK1, 2, and 3. And Bari also has some activity at TYK2. I mean, people don't usually talk about that, but it has pretty low IC50 values in the enzymatic assay when you look at those things. So there is some TYK2 activity for Bari as well. As you know, is really more JAK1 specific, and UPA is more JAK1 specific, although also has some activity at JAK2. So there's some crossover between all these molecules, particularly at higher doses. So, and as you mentioned, we only have the 2 milligram dose here for Bari. I assume in Australia, you probably use both doses there. I don't know.
Yeah, the 4 is used almost universally here, unless you're over 70 renal impairment, then we use the 2. So let's talk a little bit about the results, and then we'll take it from there.
When you looked at what we published here, we showed overall across the trials, if you just looked at an all exposure group of Bari, anyone who was on Bari, you know, the rate of serious infection was kind of that sweet spot we see with all the JAK trials and really all the biologic trials, around 3 per 100 patient years. I think that was our number. And, you know, when you looked at the 2 doses, they were pretty similar. They weren't statistically different in the placebo-controlled period. In fact, the rate was similar to placebo. It was 3 versus, I think, 4.2 for placebo. You know, of course, that's short term. That's only through 24 weeks. But when you looked at beyond that, between 2 and 4, of course, there's no placebo patients after that time period. But when you look between 2 and 4, again, pretty similar, although maybe some dose-dependent increase, a hint there where the rate with Bari 4.8 with the 4 milligram dose and 3.3 with the 2 milligram dose. So maybe some different there, but not statistically significant. And I wouldn't be surprised if there was some difference there, because 4 is more efficacious than 2. So I would expect there to be a bit more of a signal with 4 compared to 2. But those rates are right in the ballpark. And in terms of the types of infections, it was the usual stuff you see in RA, you know, pneumonias, skin and soft tissue infections, UTIs, etc.
With the TNFs, it seems that serious infection like skin and soft tissue drops off over time. You didn't get a hint of that in this study?
Yeah, it's an interesting idea. Yeah, sure. I mean, the LTE experiences in all these studies, you do see either fairly stable rates, but you always see them slightly decline. And so these rates also decline slightly with time, which is what we'd expect. So, you know, in terms of risk factors for SIEs, I mean, it's kind of the same serious infection risk factors as we see elsewhere. I thought the coolest part of the data, the modeling though, is that we looked at BMI not in one direction. We looked at, you know, whether you're underweight or overweight, and it turns out both are risk factors relative to being normal. So that was interesting. We don't usually look at it that way, but that makes sense to me. And then of course, concomitant glucocorticoids was a risk factor for serious infections. No big surprise there, in addition to age.
But with steroids, any cutoff, or all doses are not good?
Well, you know, we found a similar risk for, you know, people under 5 milligrams per day, as well as between 5 and 10. It was about the same. I would suspect if you had a bigger trial, more power, you'd see a higher risk estimate for, but we didn't see one.
I think there's this impression that 5 or less is safe, but really from an infection point of view, I'm not sure that's really true.
I agree. You know, Mike George and I and Jeff Curtis and a number of other people just published a study in Annals of Internal Medicine this week looking at that. You could grab it and look at it, but it was where we looked at even lower doses of steroids, and we controlled for disease activity in various ways, including, you know, your usual measures of disease activity for RA, and we were able to show that increased risk as well. So I agree.
Good on you. Tell us a bit about TB, and then we'll talk about Zoster.
I don't think there was a surprise to TB either. It occurred. I think all the cases were in the 4 milligram group, but of course most of the program was in the 4 milligram group. So I don't think we could really comment on a risk difference according to dose. The cases occurred in endemic areas for TB, and they occurred at rates between 3 and 5. Or slightly higher times above the background population, which is really similar to what we saw with TOFA and their RA program. Certainly similar to what we see with the TNF blockers in population-based studies from those places in the world. So I wasn't surprised by this. I think there were 11 cases, if I remember right. But, you know, alongside that, there was a nice screening algorithm put in place. It was similar to what we've done in a number of programs for a number of agents. And the people that were found to have latent TB and treated did not reactivate. They tolerated their therapy, you know, and they were able to go into the program. If I recall right, I think they had to be on latent TB prophylaxis for a month before they could start the study drug. So, you know, people would start Bari or placebo at that point, and they had, of course, finish out their LTBI treatment. And they seemed to tolerate INH and Bari just fine together. We looked at that in a separate publication, and rates of hepatotoxicity were really low. So it proved, or, you know, it suggested that, hey, you can do this how we did it with TOFA and how we do it with other drugs, screen people effectively and prevent TB. So.
Okay, so we've got to do the normal screening. Can you just remind me, wasn't there a New England paper of a sort of a rifampicin derivative and 3 months is enough instead of 9 months of isoniazid?
Actually, in some of the patients with Bari in this trial, they were actually treated with rifampin-based regimens. So not all of them were on INH, as opposed to where we published that data a few years ago. Those folks on INH because rifampin interacts with TOFA. So rifampin-based regimens, which are short alternative for these folks in this setting, and the drug you're talking about is rifapentine. It's a long-acting rifampicin. So, you know, once weekly INH and rifapentine for 12 weeks is really the preferred regimen. It's the most straightforward, probably the most efficacious, and it's only 12 weeks long. So that's what I'd go for if you can do it.
Yeah, we have to get my head around that. It's a new way to go. So tell us a bit about Zoster, which if we work in the Asia Pacific is the biggest issue of all.
Yeah, I mean, nothing surprising necessarily with Zoster, except for the multivariate analysis of risk factors. We didn't see that steroids added risk, so that was surprising to me. But that may just because we have a too small study or something, because steroids are undoubtedly a risk factor for Zoster, and that's been shown in dozens of publications. In terms of the rates of Zoster, sure, they were elevated compared to placebo. There seemed to be some suggestion of a dose dependence. You know, the rates were higher with 4 as compared to 2. They were certainly higher in your part of the world, particularly Asia. And again, this was driven by highest rates being in Japan. So very similar to what we saw with tofacitinib and upadacitinib, where there's a lot of that data. And again, nobody really understands this Asian signal in terms of why these folks get more Zoster or why they have more Zoster captured when they're taking JAK inhibitors. So I think the Zoster signal here was very similar to what we've seen with the other drugs, despite being slightly different in terms of their kinase selectivity that we spoke of earlier in the podcast. I guess the other thing to note is that similar to the other programs, you know, these were mostly monodermatomal. A few of them were, you know, multidermatomal, but there's no invasive disease really, and it's generally easily treatable with an antiviral and stopping the JAK. And so same kind of profile we've seen with the other agents and probably what you've seen in clinical practice. It certainly speaks to the need for vaccination and prevention. We're starting a big trial looking at Shingrix in a setting. There's a couple other studies. Actually, we're starting several studies looking at Shingrix in the JAK inhibitor setting with several partners. And so I think this is, you know, in the next year and a half, we're gonna have a lot better idea how well that vaccine works and optimal ways to give it, you know, in relation to DMARD use, because I think those are big.
Yeah, it's sad we're stuck with the Zostavax here, and it comes at the worst time. The patient's flaring, need to go on a JAK, and you've got to say 2 or 3 weeks off before we can, you know, so it's quite tricky here.
Yeah, that is trickier where, yeah, I totally agree. Now, it's interesting. I mean, I would still use Zostavax. I mean, it certainly, I think, provides some benefit. It's probably just much shorter term than the Shingrix. So it would be a nice bridge to use it for the next year until maybe you have Shingrix available. But the live aspect to it is an issue, as you mentioned. So yeah, try to do it when they're not flaring and they need to start their JAK. I guess that's it. I'll tell you, Jeff Curtis and I, it's not published yet, but I mean, we showed that you can use Zostavax in patients on TNF blockers without any problem at all. So, that's probably the time to vaccinate them while they're on their TNF blocker.
The other thing was interesting, in the TOFA studies you published, if you eliminated methotrexate and steroids, the Zoster risk came all the way back down to baseline, but you didn't show that with Barry. Is that just a quirk of the numbers?
Yeah, good observation. I think it was a quirk. I mean, in fact, with the TOFA data, when we got more person years or more data, we were able to show that it actually really wasn't influencing us much at all as well. So I think most of the influence that we're seeing was with the concomitant steroid. So I think you raise an interesting question. I mean, maybe there's more, interaction going on with steroids in TOFA than there are with steroids in Barry. I don't know. I mean, in the SIE data, we see something similar, but in the HZ or the herpes zoster data, of course, we saw something different. So that's an open question. I don't know why that would be, other than it's probably a fluke, or it's, we just don't have large enough data sets, but interesting to follow that up, particularly as we get more person years exposure accrued. We should reanalyze that.
And you're studying it now, but do you get the impression Shingrix flares RA or has no real effect on RA?
Well, I can tell you my personal experience is very small. And one person flared out of maybe, a couple dozen. So I don't know. I mean, their flare rate seemed to be well expected. Of course, there was no control group. They didn't really, it was an observational study. It wasn't a rigorous, case finding exercise for flares. So I don't know, maybe they missed some flares, but from what they reported, it was encouraging, and it didn't look like there was more flares than what one would expect.
Yeah, very, very few people had to change treatment. Yeah, that's true. Any future developments in this program? Should we wait for registry data now? Have you done enough of this looking at the long-term extension? Where's the future for Barry, and where's the future for the 2 doses as far as safety is concerned?
Yeah, I mean, I think twofold, two answers. I mean, one is obviously the VTE issue, which we're not talking about today. That's something that needs further evaluation. Of course, that's ongoing, and that plays a lot into the 2 doses. I think from an infection standpoint, I see a benefit risk that's favorable for the higher dose with regards to infection. It's really, the 4 could be used in people who need it, certainly, and the 2 could be used in people who have not bio IR times 5 and things like that, or they lack risk factors. I mean, certainly older people, I think you've got to be a little more conservative with in terms of your dosing, not just with Barry, but just with any of your drugs. That's been shown with TOFA 10 versus 5 and a lot of these other drugs that, higher doses, particularly in elderly people, are riskier. The risk elevation in elderly people is really, the relative risk is really no different. I mean, if increased risk tends to be the same whether you're 35 or 75, it's just your absolute risk, of course, is a lot higher. So I think, I guess to me, obviously shingles prevention is really of utmost importance to JAKs. Long-term, we have a little hepatitis B data. We didn't talk today, but that looked pretty favorable with Barry. I mean, we were able to show that Barry does react to B, which I expected, but also that you can watch people closely and use Barry, even if they have a history of HBV exposure. And of course, use antivirals if you need to. So I think that was encouraging. So, I mean, in terms of the future, sure, registry data, it's always important, or population-based data. I think we should probably look a little more at the elderly and then also at shingles prevention. Those would be the two things on my mind.
I forgot to ask you about other viruses. Some of my patients complain of herpes simplex being an issue on all JAKs, not just this JAK. And should we be extra cautious with HPV and use Gardasil in our patients?
Yeah, those are good questions. I mean, I should have said that because HSV, I guess I'm convinced that all these drugs cause HSV. We looked at that with TOFA a couple years ago and showed that Jeff Curtis and I did a study together looking at that. And that's been reported in some of the other JAK inhibitors, particularly those being used in atopic dermatitis. But there's not a lot of data with very specific to HSV. I'd be keen on collecting it. I think HPV is an open question. We haven't seen an increase in HPV related cancers in any of these programs. Even up to, several years of long-term follow-up. But of course, a lot of these people aren't necessarily at risk, or older, at least with cervical cancer, maybe past that window of new HPV infection or something, or they've cleared their initial HPV infection. So I don't know. I think that's an area that would be ripe for an open study, an investigator-initiated project looking at particularly younger women who have HPV and seeing how these drugs modulate that. This may be more of an issue for some of the lupus trials to address, but I think that's an open question. I don't think we think it's a big problem right now based on the long-term malignancy data, but I don't know of a lot of, or really any viral-based studies that have looked at that systematically.
I just think it's something we should look at. Anifrolumab in lupus is coming. I think it might be something worth looking at. So finally, any other take-home message? We know we've got to be same infection risk as any other advanced therapy. Zoster, we recognize we've got to vaccinate, minimize steroid use. Any other take-home message?
Yeah, I think you just nailed them. And, vaccination is key. I mean, we didn't talk about other vaccines, but we did a study with Barry, and, people responded well to PCV13 and the conjugate Pneumax, or the conjugate pneumococcal vaccine, or Prevnar it's called. And they responded a little bit less favorably to tetanus, although there was pretty decent response. So, I think it's important to remember right now we have flu season, which is coming up here. You're coming out of it. And then we have COVID coming in terms of a vaccine. And we have Barry also being used against COVID, which, you saw that there was some favorable data in a press release about it last week in terms of improving clinical outcomes on top of remdesivir. So there's a lot to think about with Barry in the next year with regards to viral infection, I think. So prevention of influenza, of course, key. And then I think, how it may or may not affect COVID outcomes, of course, is really of utmost interest. And there's a number of trials looking at that. So it's exciting times, I think. And I guess that's probably the last thing I'd say about Barry. Just buckle up. It's exciting. We'll see what happens in the next year.
So thank you so much for your time, Kevin. This has been the CSF Author Interview Podcast. If you'd like to know more about this paper and others uploaded to the CSF website this month, you can get detailed slide sets available in the publication section at cytokinesignaling.com. Please subscribe to this podcast on iTunes or wherever you get your podcast from, and let us know what you think. We always appreciate a bit of feedback. Thanks so much, Kevin.
Thanks, guys. Thanks, Peter. Take care down there.